Hi everyone, my name is Grace Nixon and I'm an APRT student here at UW Health, and I'm very excited to present to you my presentation entitled Stop the Spill, Overview of Proteinuria Reduction Strategies in CKD. I'd like to thank my content expert, Kim Hildener, for her support of this presentation. So my main objective, I hope by the end of my presentation that you'll be able to describe the relevance of proteinuria measurement in CKD, assess the clinical utility of three classes of medication: ACE inhibitors and ARBs, SGLT2 inhibitors, and then mineralocorticoid receptor antagonists in CKD, and then recommend appropriate medications to slow kidney disease progression in a CKD patient. So we'll start out with a broad overview of CKD and proteinuria. So as you likely recall, CKD is defined by the KDIGO 2012 guidelines as either a decreased eGFR of less than 60 or markers of kidney damage in a person for more than 3 months. Markers of kidney damage are defined by the guidelines as any of the conditions listed here on this slide. I'm not going to cover these extensively, but I wanted to point out specifically that albuminuria, or the amount of albumin protein in your urine, is an important measure of CKD progression, and it is mentioned in the KDIGO guidelines. So what is proteinuria, you ask? Well, proteinuria is an umbrella term that simply means increased levels of protein that spill into one's urine. This can happen for a few reasons, but often the vessels and the cells of the glomerulus are damaged, which then impairs the normal filtration abilities of the kidney, leading to protein being filtered out when it is normally not. When there is more proteinuria, there is likely more kidney damage. There are a few ways to measure this protein spill. The term proteinuria refers to a measure of all types of proteins that can spill into the urine, and then albuminuria specifically refers to the albumin protein in the urine. So in the KDIGO guidelines, they provide two nice graphs that show that increases in proteinuria are associated with increased all-cause mortality and cardiovascular mortality. So on the graph here on the slide, you can see that the albumin to creatinine ratio, or ACR, is on the x-axis. And as the ACR increases, mortality in both all-cause mortality on the top and then cardiovascular mortality on the bottom increases in a linear fashion. So now that we know that proteinuria is an important marker of kidney function decline in CKD with correlations to mortality, both cardiovascular mortality and all-cause mortality, what can we do about it? Well, let's talk about some medications that we can use to slow CKD progression and decrease proteinuria. So I'm going to cover three main classes of agents that we use in this situation. The first is ACE inhibitors or ARBs. Second is sodium glucose cotransporter 2 inhibitors or SGLT2 inhibitors. And then mineralocorticoid receptor antagonists or MRAs. I think my presentation will dovetail nicely off of Deanna's presentation earlier, and so hopefully I can provide a little bit more context about the use of these agents beyond what she discussed. So for ACE inhibitors and ARBs, let's start out with them. As a refresher, they are renin-angiotensin-aldosterone system antagonists, which then lead to sodium and water excretion. This mechanism of action can be beneficial to CKD in two ways. First, it decreases the blood pressure, and hypertension is a known contributor to CKD progression. And then secondly, angiotensin 2 is responsible for the constriction of the efferent arteriole, which is shown here on the left-hand side of the picture that I put on my slide. So when the efferent arteriole is constricted, it builds up the pressure in the glomerulus, and then this hydrostatic pressure leads to more protein being filtered out into the urine. So by antagonizing the action of angiotensin 2, which is shown here on the right-hand side of the slide with the ACE inhibitor and ARB. The ACE inhibitor ARB actually dilates the efferent arteriole, which then reduces the capillary pressure within the glomerulus and leads to less proteinuria. ACE inhibitors and ARBs are recommended by KDIGO guidelines, and they've been recommended for quite a while. For a person with microalbuminuria, which is defined as a urine albumin excretion of 30 to 300 milligrams in 24 hours or the equivalent, they should be put on an ACE inhibitor and ARB if they have diabetes with their CKD. For people who have macroalbuminuria, so a urine albumin excretion of greater than 300 milligrams per day, they should be put on an ACE inhibitor and ARB regardless of their diabetes status. There are a few pros for use with these medications. First, we don't want to use an ACE inhibitor and ARB together, as studies show that they can significantly cause hyperkalemia and AKI. Second, the goal is to titrate these therapies to max tolerated dose for the best renal benefit. And then as an important note, if someone does not have proteinuria associated with their CKD, any antihypertensive can be used, and there is not a specific recommendation for any antihypertensive specifically with ACE inhibitor and ARB. You can use any medication, but ACE inhibitor and ARB could still be considered in this situation. So we'll move on to our second class of medications, which is SGLT2 inhibitors. So to refresh your memory on their mechanism of action, they block the SGLT2 protein in the proximal tubule of the nephron, which then blocks glucose and sodium reabsorption. This again helps the kidneys in two ways. First, it also decreases the blood pressure, and blood pressure, as we know, is associated with CKD progression. And then secondly, it increases the sodium delivery to the macula densa. So let me break this down a little bit more for you to know how to be beneficial in CKD. So in CKD, the afferent arteriole is actually abnormally dilated as a compensatory mechanism to maintain urine or blood flow to the kidneys. So as an SGLT2 increases the sodium delivery to the macula densa regulatory cells in the nephron, this leads to constriction of the afferent arteriole. This constriction leads to less blood flow and fluid delivery to the glomerulus, which then would decrease the interglomerular pressure and then decrease proteinuria. So SGLT2 inhibitors were previously not listed in guidelines. However, the new 2022 KDIGO diabetes and CKD guidelines that just came out last week do recommend them as first-line therapy for people with concurrent diabetes and CKD. Unfortunately, the guidelines for CKD patients without diabetes are still not updated. In fact, they just referenced the guidelines from 2012, but there is data supporting their use. So here on this slide, I included 3 studies, and for the sake of time, I won't go over them extensively, but I wanted to point out a few important things. So on the left, we have the DAPA-CKD trial, which was the first and only RCT done for SGLT2 inhibitor renal outcomes in people both with diabetes and without diabetes. And it found a significant decrease in the composite adverse renal outcomes. The other 2 trials here on this slide are meta-analyses of SGLT2 inhibitors, which show reductions in proteinuria of about 25 to 30% compared to placebo. So when thinking about the use of an SGLT2 inhibitor, it's important to know that dapagliflozin is currently the only FDA-approved SGLT2 inhibitor for CKD without diabetes. The others have not been studied in this patient population to determine if it is a class effect yet. It's also important to consider compelling indications, as some SGLT2 inhibitors have gotten FDA approval or are better studied in certain conditions. So for example, in heart failure, dapagliflozin and empagliflozin have FDA approval, but you could consider other SGLT2 inhibitors as you would like. And then with type 2 diabetes and proteinuria, canagliflozin and dapagliflozin have specific renal outcomes trials, but then you could also consider empagliflozin because they had renal subgroup analyses in a cardiovascular outcome trial. These SGLT2 inhibitors may have a significant diuretic effect, so often patients who are on other diuretics may need to have their dose adjusted of those medications when they start an SGLT2 inhibitor. These also have a mild blood pressure reducing effect of about 4.5 millimeters of mercury for the systolic blood pressure. And then renal dose adjustment is necessary for these medications as they can cause a transient decline in EGFR that resolves in about 3 to 4 weeks. For our third class of medications, we have the mineralocorticoid receptor antagonists, which block aldosterone action at the mineralocorticoid receptor. This then leads to sodium excretion and thus blood pressure reduction. They also decrease aldosterone-mediated inflammation within the kidneys, and it is an important mechanism because experimental evidence suggests that the RAS blockade with an ACE inhibitor in ARB leads to incomplete suppression of serum aldosterone via aldosterone escape phenomenon. And so, long story short, there is a potential benefit to using these medications in combination with an ACE inhibitor in ARB to block aldosterone action fully. There are 2 main types of mineralocorticoid receptor antagonists. First are steroidal, which are spironolactone and eplerenone, and then there is the non-steroidals, which Deanna has so wonderfully covered earlier, which are finerenone and esaxerenone. So I'll spend time discussing finerenone as it was recently improved and is gaining for use, but I will not be discussing esaxerenone as it has a higher risk of hyperkalemia and does not yet have proven kidney and cardiovascular benefits like finerenone. So let's start out with the steroidal MRAs. Spironolactone and eplerenone have data supporting their ability to reduce albuminuria. So they do lack trials relating to clinical kidney or cardiovascular benefits in CKD, except if somebody has heart failure. Importantly, they also often cause dose-limiting hyperkalemia, especially in CKD patients who are already on an ACE inhibitor and ARB. You can see this in the trials that I included on this slide. Highlighted in red there is that there's a relative risk of hyperkalemia of 2.0 in one of the studies that I found, and then 2.63 in another. And that's compared to an ACE inhibitor or ARB alone or to placebo. So we definitely want to watch potassium levels if we choose to use these in CKD. All right, now I want to talk about the new kid on the block, finerenone, which is a non-steroidal mineralocorticoid receptor antagonist that has been shown to reduce albuminuria and CKD progression and has potentially less risk of hyperkalemia than steroidal MRAs, but there have been no head-to-head trials. Most of our data for finerenone right now comes from its RCTs that Deanna talked about, and that led to its FDA approval in 2021. Fidelity, which Deanna did not cover, was a pooled analysis of these two RCTs that combined the finerenone effects to placebo in people with CKD and type 2 diabetes with proteinuria on max tolerated doses of ACE inhibitors with ARBs, and then with or without the SGLT2 inhibitor. This is the forest plot of results from the pooled analysis. Anything on the left of the diagram favors finerenone, and then placebo would be favored on the right. For all efficacy outcomes assessed, finerenone performed very well. In particular, I highlighted in red the renal composite outcomes, which finerenone had a statistically significant reduction in adverse renal events. I also included the adverse reaction data here on the right-hand side of the slide. As you can see, finerenone did come at an increased risk for hyperkalemia, but a relatively small percentage of patients had to stop the drug due to hyperkalemia. With any medication in CKD, we worry about it causing an AKI. So the good news with finerenone is that it has similar rates of AKI to placebo. And then to talk through some pros for using finerenone in a clinical setting, currently it is only FDA approved for use in CKD with type 2 diabetes. So as Deanna mentioned, the ADA 2022 guidelines were actually updated to include recommendations for its use in CKD patients with an increased risk for cardiovascular events or CKD progression, or people who are unable to use an SGLT2 inhibitor. Finerenone is also mentioned in the brand new KDIGO diabetes and CKD guidelines that just came out, and it is now recommended for people with persistent proteinuria with type 2 diabetes already on an ACE inhibitor and ARBs. Generally, an SGLT2 inhibitor can have beneficial effects with the finerenone, so KDIGO recommends the trial of an SGLT2 inhibitor first before adding finerenone, so it can be used in patients just on an ACE inhibitor and ARB too. Dosing for finerenone is a little bit odd, as the initial dose is determined by renal function, and then the maintenance dose is determined by serum potassium levels. So I'd encourage you to check out UpToDate, which matches the brand new KDIGO guidelines for specific details on how to dose finerenone. This medication is primarily metabolized by CYP3A4, so it is recommended to avoid strong CYP3A4 inhibitors and moderate to strong CYP3A4 inducers. The main adverse effect that we worry about is hyperkalemia. So we want to check a BMP within 4 weeks after starting or making a dose change. And we want to be cautious with any other medications that can increase potassium. If hyperkalemia does occur, a hold of 72 hours of the finerenone would be recommended and is often appropriate given the medication's half-life. And then here I wanted to briefly mention that the KDIGO guidelines actually recommend that for people on a therapy that modulates CKD progression, like an ACE inhibitor or an ARB, or the other therapies that I've talked about already, to experience hyperkalemia, try potassium management strategies like a low potassium diet or potassium binders before decreasing the dose of the medication that modifies the CKD progression. So I'm assuming that this recommendation that is specifically made for ACE inhibitors or ARBs in the guidelines would also carry through with finerenone, but it is not in the current guidelines. Also with finerenone, it does have a weak blood pressure lowering effect, but it does not have changes in glycemic status or sexual side effects like spironolactone does. And it is also, as Deanna mentioned, still a branded medication, so it can be very expensive. So to put all of the MRAs into context and kind of wrap it up in a nice bow, the KDIGO 2022 diabetes and CKD guidelines generally recommend a non-steroidal MRA over steroidal MRA if someone does have diabetes and CKD, given that they have long-term outcomes data. But you also want to consider indications that a person might have for a steroidal MRA, such as heart failure, primary hyperaldosteronism, or refractory hypertension. And the most pressing clinical condition for a patient with multiple diagnoses should be prioritized. There's definitely a need for more comparison data between these MRA classes to get better recommendations for use in the future. All right, so that brings us to section 3, where I'm going to put everything that you learned together kind of in a nice format to help us select therapies for people in the future. So I made this nice summary chart to kind of describe when and where we would use various of these agents. And so let's review this together. So as we talked about with ACE inhibitors or an ARB, almost everyone with proteinuria gets this medication. If they have microalbuminuria, which again is greater than 30 milligrams per day of albumin excretion. That would be people who have CKD and diabetes who would be indicated for the ACE inhibitor arm. If they have macroalbuminuria, which is greater than 300, any CKD patient would be qualifying for an ACE inhibitor arm at that point. ACE inhibitors in ARB can also be good for blood pressure management and CKD those people who don't have proteinuria. And you're going to titrate this therapy to the max tolerated dose while watching serum creatinine and potassium. Then we think about our add-on therapies. So first we got the SGLT2 inhibitors in the middle pink column. Anyone with CKD and diabetes, regardless of their glycemic status, is recommended to be on these therapies. And dapagliflozin, importantly, is the only FDA-approved SGLT2 inhibitor for CKD without type 2 diabetes. These do have a minimal blood pressure lowering effect, but it does have a significant diuretic effect, so you'd want to consider the dosing of those other diuretics. It is renally dosed, and we want to consider the compelling indications when we select a specific SGLT2 inhibitor. And then finally, on the right-hand column of this table, we have the MRAs. This is an add-on therapy to an ACE inhibitor arm for people with diabetes. We'd want to consider adding an SGLT2 inhibitor first, as these might reduce the hyperkalemia side effects of an MRA. And usually non-steroidal MRAs, like Cenerimod, would be recommended over steroidal, just due to the outcomes data and possibly less hyperkalemia risk. However, they do come at an increased cost, and we should consider the compelling reasons for a steroidal MRA that I already discussed. We do need more evidence on these therapies. There is a minimal blood pressure effect and no impact on glycemia. And then, as we briefly discussed, we'd also want to consider renal function and serum potassium for dosing. All right, so that kind of sums up a big complicated topic, and I hope that was helpful. Here are my references. I would love to answer any questions that anybody has at this time. I'll put the signing code up as well.